for that. Let's turn now to Dr. Wael Abdel Razek. He is the professor of hepatology and gastroenterology at the National Liver Institute in Manafia University, head of primary health care in the nursing sector at the Ministry of Health and Population, and he's the deputy executive director of the National Committee for Control of Viral Hepatitis in the Ministry of Health and Population of Egypt. And I want to thank Wael for coming on and look forward to your remarks. Thank you.
Thank you, John, for the introduction, and thank you for the kind invitation. First, a glimpse about the magnitude of HCV problem in Egypt. In 2014, we had the highest prevalence in the world, and we had as many patients as in 38 countries in Europe, excluding Russia. In 2010, we had the highest age standardized cirrhosis mortality, and almost 1/5 of all deaths in males 45 to 54 years old were due to liver cirrhosis. Regarding the diagnosis rate and treatment rate, we had the lowest diagnosis rate and the lowest treatment rate, and the bubble represents the number of patients. So we had the high number of patients, but this is no more the case. In 2008, we did a demographic health survey, and we discovered 9.7% of seroprevalence and of RNA prevalence. And in 2015, this prevalence was reduced to 7%. These are the phases of HCV management in Egypt. We started in January 2007 with pegylated interferon. We treated almost 300,000 patients with an SVR of 40%. In October 2014, we started using brand DAAs at 1% of its price in USA. Then in January 2016, we started using generic DAAs after comparing them to brand DAAs and ensuring that their efficacy and safety were as the brand DAAs. In this era, we treated almost 2.5 million patients who were aware of their infection with an SVR of 96%. In mid-2018, less people who were aware of their diagnosis registered for therapy. And in October 2018, we started the nationwide screening program with a target of all citizens above the age of 18, which accounts for 62 million citizens. The famous so-called 100 Million Healthy Lives Initiative. The initiative was enrolled in 3 phases. Each phase included 7 to 11 governorates with 5,000 to 7,000 fixed sites and 17 to 23 million to be targeted in each phase. Most of the screening was done in the primary healthcare units. The screening presented us the heat map of HCV and NCDs, as the screening was not only for hepatitis C, but also for non-communicable diseases, namely diabetes, hypertension, and obesity. And for the first time, we had the HCV prevalence in Egypt to the district level, not only the governorate level, and which was published in New England Journal of Medicine. The fast deployment of screening in 7 months was a huge test for the healthcare system. The infrastructure, we had PCR hubs of 77 devices with a capacity of doing 27,000 samples per day, distributed all over Egypt. We had the kit supply chain, the samples transportation chain, the maintenance system for these devices, the lab information system to have the result of the PCR in the treatment center once the result is generated. We went to Africa with PCR devices that were used thereafter in the COVID PCR. We had in-house programs for the screening initiative and also for the COVID-19. The data entry in these programs, the data entry clerks were trained and they were ready for COVID-19. We had the immediate linkage to care once the patient was screened. Once the citizen is screened and turned positive for antibody of HCV, was immediately linked to care with an appointment in the treatment center. We have updated our data registry, which was implicated positively in the COVID era. And this was used also in the COVID-19 vaccines, the same systems. And as you can see, this is a very simple system for hepatitis C and the NCD screening. And we used also telemedicine in the treatment of patients with chronic HCV in remote areas, and which was published in Liver International, which was used effectively in the COVID-19 era. The elimination necessitates to prove not only screening, diagnosis, or treatment, but a sustainable healthcare system that starts from prevention and ends by reduction of viral hepatitis-related mortality. Therefore, we apply the 360 degrees uplift of all elimination pillars in the Egyptian healthcare system. Maybe the COVID-19 slowed down the program efforts. Most hospitals were shifted to COVID-19 response in the beginning. Patients were afraid to go to treatment centers. Screening needed to document reduction of incidence, which was postponed. However, we have a lower caseload and mortality than North African peers and shorter lockdowns. As a result, economy experienced growth during the first year of the pandemic at the time of the global economy shrinkage. So in conclusion, mass screening for HCV and NCDs was a huge test for the healthcare system in Egypt, which came just in time, just before the COVID-19 pandemic. Multiple lessons were learned and applied to COVID-19 response. COVID-19 relatively slowed down the elimination program and relatively delayed the certificate. However, all these lessons helped reduce the COVID-19 burden in Egypt, and we are looking forward to be the first country to be WHO certified for hepatitis C elimination after being the highest in prevalence. Thank you very much.